Hi, it's Kay Van Wey, and welcome back to another episode of AdvoKAYte, Holding Healthcare Accountable. I'm super excited to have as my guest Ann Roberts. Ann, if you've been listening to the podcast, you know that Ann is a C-suite executive with a large and prestigious medical institution in the Northeast United States. And Ann, she's one of the good guys, I'd like to say. Although she works in healthcare, she is very much a patient safety advocate. In this episode, we're going to be talking about just culture and what is a good and proper culture for a hospital to have. Do they have a corporate culture of drive profits, profits, profits? Or do they have a culture of patients first, patient safety first, and what that requires and what it looks like? So I'm super excited to have Ann back for another episode. Thanks for joining. AdvoKAYte, Holding Healthcare Accountable. This podcast is my way of sharing what I've learned about the mistakes, the cover-ups, and the ways we can all protect ourselves. We're all in this together. That is a great segue into the discussion about physician autonomy because, any medical malpractice defense lawyer worth his or her salt will always invoke the corporate practice of medicine defense. When you have a medical malpractice case where there's a doctor and a hospital involved, hospital always says, we don't tell the doctor where to make the incision. We are prohibited by law from telling the doctor what diagnosis to make, what medicine to prescribe, or whatever. But every doctor will tell you to say, well, that's true. They don't tell me where to make the incision, what diagnosis to make, what medicine to prescribe. But it would not be true to say they don't have influence over a lot of the daily decisions that we make and how we operate, so to speak. So can you just kind of walk us through how hospitals regulate doctors, what their responsibility is for the doctors that operate at their facilities, and then what the difference is between the distinction between corporate practice of medicine and not?
Sure. So I always start with the medical staff because we already know that on the business side, you're going to have, as I mentioned, legal, C-suite, business administrators that are there to focus on the business side. So I tend to focus on the structure and the governance of the medical staff and their decision making and what their roles and responsibilities are. And so in a hospital, you have, and a lot of organizations are moving more towards an employed model, and I'll get to that, but you have to separate the two because in the hospital structure, the physicians have, what's called the medical staff, where all the physicians join, and depending on their levels of activity, grants them certain privileges or rights on the medical staff and administrative and clinical. And of course, everything patient safety, including the medical staff, reports to the governing body, but they consider the medical staff as self-governing. And so they have a structure where you have a medical executive committee called different things in different organizations, but from a regulatory perspective, it's typically called the medical executive committee. And everything related to policies, procedures, protocols, the bylaws, everything rolls up through that committee, and they have the primary oversight of the practice of the medical staff. They're responsible for establishing what they believe is best practice. They write the bylaws that govern how physicians practice within their organization, their qualifications, how often they're reviewed, what the documentation requirements are, how they want that documentation to look, because a lot of that is dictated by regulatory agencies. And so they have the medical executive committee. That is the committee that oversees the medical staff. You have physicians that are appointed in leadership roles. And so you typically will break down a hospital by specialty, and you'll have a department chair or division chief that specialize in that area. So, for example, Department of General Surgery, internal medicine, family medicine, OB/GYN. You have a physician leader assigned to oversee the entire practice within that specialty. And they are responsible for complying with the overall rules, regs, the medical staff, but also setting best practice for their specialty and within. And so when you look at that, they do, again, partner with administrators such as myself to say, okay, we need help in drafting these bylaws. They consult legal. We need help in making sure what we want to do meets regulatory standards. And we need to make sure that we're complying with all of the other, regulations, while also doing their job at doing what's best for patients and recommending protocols that are, safe. As far as administrators or other hospital leaders and their corporate practice of medicine and being able to dictate how a practitioner practices or the types of things, you're right, they're not going to dictate what type of incision or the diagnosis is 100% the responsibility of the physician. There is nobody that can or should question that. But is there that partnership where, yes, they can have influence because there's financial implications for the organization. They can have influence because they have to make sure that the legal and regulatory standards are met. And oftentimes that means educating the physicians on what those are. So,
Well, just to follow up there for just a minute, it's the best practices are dictated by partly by the professional organizations, the relevant professional organization, whether it's the American Board of Neurologic Surgeons, the American Society of Anesthesiology, or whatever it is. And those organizations, so if you're an anesthesiologist, your organization is the American Society of Anesthesiologists. And they get their best and brightest to form little committees to study certain things and come up with clinical practice guidelines. They don't call them best practices. They don't call it the standard of care. They're very careful to say these are just suggestions, guidelines, or whatever, but we all know they are intended to be, this is the best and most approved way to do it.
Right.
And then those can become codified into all different kinds of things, like order data sets, policies, procedures. And so the hospital isn't saying, okay, doctor, emergency room physician, if a patient comes in with chest pain, we're going to tell you what the diagnosis should be, or we're going to tell you whether this patient needs this treatment or not. But they're providing clinical pathways, predetermined algorithms so that patients are moved along the pipelines to get the doctor to reach the right diagnosis and treatment plan. Is that, did I garble that, or is that kind of a generally right?
I think it goes back to what I'll just continue to say. It has to be a partnership. So yes, they're going to build in, safety checklists. They're going to put order sets and everything. But those should be developed with the input of the physician leaders. So those physicians that are chairs, those physicians that sit on the medical executive committee are the ones that have input and provide guidance in regards to, does this plan of care, does this care pathway work, and does it focus on patient safety? And so, again, it has to be that partnership, because if administrators, I'm not clinical, so I can tell them, this is what the law requires. This is what regulatory agents, say. We've done the research. This is what it says best practice should be. But that may change depending on staff, resources, equipment, whether or not the physician is specifically trained in a certain area. So the business administration of the hospital can give them the tools and resources which may or may not be adequate. It depends. But it is the physician's obligation. And
Mhm.
even if they put something into place, the physician still has the right to say, I'm not doing that. It's not safe for patients.
Right.
Will that go over well? Probably not. And it depends on the organization. But they also should be consulting with their physician leaders who helped design those practices. It is the medical staff that writes the bylaws. They vote on it. The entire medical staff who have voting rights vote on those bylaws and policies and procedures. And so it's not typically administrators that are developing them. They're partnering with them to do so in good hospitals.
Right. Well, one thing that a hospital does that affects the quality of the treatment that the physician prescribes is the employment of nurses and other healthcare providers. So first, let's talk about how the hospital governs or manages nurses. Kind of what's the chain of command for nurses? Mm-hmm. And then we'll talk about some of the issues that there are.
Sure. So on the medical staff side, we have a chief medical officer for each hospital. And on the nursing side, they have a chief nursing officer. So ultimately, the chief nursing officer, like the chief medical officer, are guiding, every aspect of the nursing support within the hospital. They're looking at, competencies, staffing levels, and what does the organization need for each area to ensure they're providing safe, quality patient care. What is the education and training for nurses? Because it's not just you have an RN degree, we're going to set you loose. Right. There are subspecialties that they have to have experience in. So you can't just be an RN graduate and then go work in OB-GYN and expect to, hit the ground running. They have to have that education training. That is the nursing leadership's duties and responsibility to make sure the nurses have the appropriate training, that they're monitoring their performance on an ongoing basis, just like the medical staff does with the physicians. Staffing levels, same thing. If they are required to staff a unit, they have to have, they need to know the volume, of patients, the complexity of patients. They have to know the physicians and what the physicians need in regards to support in order to provide a sufficient staffing to make sure that there is appropriate support for the patient care that's being provided, the type of care. And so for the nursing leaders, it's very similar to the medical staff leaders. They're responsible for making sure they have sufficient staff, resources, equipment, that their nurses are supported, and that they feel empowered to be able to speak up and stop when they say, I don't feel that this is safe. The nurses are a part of the care team. So, for example, in the OR, they participate in a timeout, and they all confirm, do we have the right equipment? Is this the right site? Right patient, things like that. And if a nurse sees something, say something. They should be empowered to feel that they can do that. And if they don't feel empowered, or they feel like they may be retaliated against, or let's say they don't feel like they're in a safe environment where they can say something, or there's a level of intimidation, then again, that's still the nursing leadership's duty to identify those issues and work to address them. If they have a toxic environment where they have a physician treating nurses badly, it's their responsibility to speak up and say this isn't okay and partner with the medical staff to address that. So,
well, a couple of things there. I have to tell another war story because you mentioned timeout, and of course it reminded me of a case that I tried and won, fortunately for the patient. But timeouts are required in a lot of circumstances, but we all know it's required that a timeout be had before any surgical procedure. And that way all the teams in there, the surgeons in there, anesthesiology, scrub nurse, radiology tech, whatever. And they're supposed to say, all right, we're all huddled together here, team. Do we have the right patient? Do we have the right procedure? Do we have the right location? We're operating on the right knee, not the left knee, whatever. And they have to document it in the chart. Mm-hmm. So this is such a great example of how you got it right on paper, but nobody beyond that gives a hoot. They check the box and they're like, oh yeah, we've got the timeout procedure in a bad hospital. Mm-hmm. The timeout was documented And then the very next thing that they did, which was start the procedure, was 1 second later.
Mm-hmm.
And so it was right there in the chart. And of course, I couldn't resist the urge to have it blown up really big. And I said, you can't even say time out. And it takes like 3 seconds to say time out,
Mm-hmm.
especially if you're from Oklahoma like I am. It's
I think depends on what state you're from.
right. New Yorker, you could probably say it. But, I think the jury, they got a kick out of it.
Mm-hmm.
Because they were probably bored to tears after a week of listening to testimony. So they got a kick out of it. But I think they were like, yeah, that's complete BS.
Mm-hmm.
You couldn't even say timeout, or you could probably even hardly click the keys to put timeout in 1 second.
Mm-hmm.
But so I understand what you're saying. And I think you're absolutely right, not to beat the dead horse, but in good hospitals, that's absolutely right. Mm-hmm. What I hear from nurses is that they're not able to do the job that they would like to do. Mm-hmm. They're not able to work their best because of business decisions that are being made, by way of example, to cut staffing, to short staff them so that they can reduce the expenditures and boost the profits. So a nurse absolutely has too many patients to take care of and can't take care of patients the way they would. And a lot of patients would say, I get that because I was in the hospital, or my mom or my husband was in the hospital, and I get it. We couldn't find a nurse in a bad hospital. And then we also hear about nurses being floated to units where, let's just say, for example, a nurse that's on the med-surg floor getting floated to labor and delivery. That's not safe. Doesn't have a clue what they're doing. But then we also hear from doctors. Doctors are largely frustrated with hospital staffing, certain hospital staffing of nurses, because their lives depend upon those nurses who are the eyes and ears. And they are getting, the nurses can't. They're understaffed. The nurses are not suitable experience level. I need this patient on hemodialysis. Well, I've never put a patient on hemodialysis before. But the doctors are also beholden to the nurses to know enough to know when to call them. And I have several friends who are physicians, and they're like, we just live in fear of having a patient hospitalized and hoping that the nurses know, if the patient develops a rigid abdomen postoperatively or whatever, they need to call me. So just things like that. So, not to overdo the point, but I think this is where the breakdown is a lot of times, is that so much study has gone into what is a very complex business, and solutions have been provided. But as the old saying goes, you can lead a horse to water, but you can't make it drink sometimes. And in bad hospitals, there are these competing pressures, especially, and I don't want to go down this rabbit trail, it's for another episode, but especially when you have bad owners, such as a hedge fund who's only buying a hospital that's in financial trouble. They intend to hold it for 3 to 5 years, make it as profitable as they can be by cutting the resources, and then turning around and selling it for, hundreds of millions of dollars profit. So again, the patient would not be able to discern the difference between a good hospital and a bad hospital.
Absolutely. And, I will say my sister is a nurse. And, of course, I've heard, her, challenges that she had as a nurse and feeling, powerless at times, but also just working in healthcare and hospitals for, my entire career. So for 30 years, you see those challenges, you hear those challenges. And then as I mentioned earlier, just like physicians, there's specialization that has to be there. And the nurse leaders have to make sure that they are placing, quality and trained nurses and partnering with the physicians to say, okay, what type of experience do you need to help you with this type of patient? And so you have fresh-faced nurses right out of school who are still learning, and they should be precepted and trained and until they learn, not just that specialty, but the way the organization itself works, handoff communication and so forth. But it is challenging. You also have to think about staffing crisis across the U.S. and staffing shortages. And, there's often times where the hospital might be doing their best, to get as many resources in there. But then having traveling nurses while they're trying to recruit is extremely expensive. But that doesn't mean that you put, profit over patient safety. If you don't have the right staffing levels, well, that's going to impact patient safety. And sometimes what I've seen is physicians will go the extra mile and stay there because they, if there's not enough staffing, then they pitch in. We've seen physicians roll up their sleeves and say, okay, well, I need to be here to help in whatever way that I can. But yes, hospitals are going to struggle with staffing, but they also have an obligation and a duty to the patient to make sure that they have sufficient staffing levels, that they have qualified nursing, and they have a duty to stop and say, okay, we unfortunately can't support this right now. We don't have this resources. They can't keep bringing in significant volume if they don't have enough staff to meet the needs of the patient. And again, with that absolute high priority, first priority of being patients, safety. Yes, it's a business. They have to operate. They have to move forward. And sometimes what patients don't see is that if they have something canceled, it may have been in their best interest to cancel it. So they might get frustrated that there's delays, something's running late, kind of like, I'm heading to the airport later, and I'm really worried right now. The flight is going to be very delayed and canceled. Sometimes it happens for mechanical purposes, and I'd much rather sit and wait and be delayed than get on a plane that may not be safe. And so when they tell me it's a mechanical issue, and I hear delays for any reason, weather, I accept it, and I just say, okay. Not quite the same in the healthcare side. Patients, they've taken time off work. They are, have scheduling. They already have anxiety about having the procedure done. And when things get canceled, it puts more pressure on everyone to make sure things keep moving forward and, the wheels are turning. But it's the hospital's duty, responsibility, nursing leaders, physician leaders, administrators to say, okay, do we have the resources to do this? Do we need to pivot? Do we need to change something? Do we need to, cut number of patients we're seeing on a certain day or certain unit if there's not, a safe way to proceed?
Right. Well, and I don't mean for this to be like everything you say, I'm like, yes, but counterpoint.
Yeah, thoughts.
The counterpoint to that is flow-through rates. And the people on the business side of hospitals that are saying, if we could increase our flow through, or I guess it would be decrease the amount of time it takes us to turn the OR over between patients, then we could probably squeeze in one extra operation per day, which would formulate out to be an extra profit of such and such every year. And so there's always a competing
Oh, absolutely. Absolutely. It's
priority.
still a business. It is still a business. They have to be able to afford to pay their employees. They have to be able to afford the equipment. They have to afford, to keep the business moving forward. The balance is, how do you do that while ensuring safe, quality patient care? It's hard to find that balance sometimes, and in a bad organization that's focused on the financial piece over quality and safety, then that's where you're going to have those challenges. But every business is going to have those struggles of, do we have, enough resources? Can we squeeze another patient in? Because it is going to bring in more revenue, especially if it's the, high revenue generating type of provider or specialist. But then it's still their duty and responsibility to say, okay, is this safe? Do we have time between cases to make sure the room, proper infection control procedures have been followed? And so it is a balance, and it's a business. So
Yeah, right. Well, I get it. And I wanted to mention that you also educate other people in similar positions, vice president level,
Mm-hmm.
people on the medical staff services committees or whatever, because I know you spend a lot of time speaking to national audiences and trying to get the message out to them about doing the right thing, and it's so appreciated. And that and a whole lot of other things resulted in you receiving an Icon Award. What is that award?
Sure. Well, thank you for that
Well,
recognition.
you're welcome.
So I've spent my entire career, now 30 years, one learning, but then also working with some of the top consulting agencies and some of the largest healthcare systems to identify what is best practice and what works best. And like I said, it is developing that partnership. And I strive to be that middle person to bring everybody together so that the physicians understand the business piece and the administrators understand the clinical piece. And so making sure there's that partnership. The Icon Award is reflecting somebody who has really advocated to, on behalf of the organization, to really focus in on safe quality care within healthcare organizations, to bring awareness to patient safety and to change and and to educate other individuals, physician leaders, administrators, credentialing staff, but my focus is primarily physician leaders on how to accomplish that. And so in my career, because I have worked so diligently in that, and even my work with you and really being vocal about systems issues and so forth, the award is to recognize all the contributions to the industry. I've helped with attorneys with providing suggestions on changing legislature to ensure that it is safe and up to date and so forth. And I do speak nationally at a lot of the large physician conferences, administrative conferences, and so forth, because I am a patient safety advocate, and that is my passion. So.
And you covered for me when I called you and said, "You're never going to believe this, but I just tested positive for COVID. Can you go give a speech for me?" And you were like, "Sure, what time?" And I was like, "Oh, in about an hour or 2 hours." But no, and it's a very well-deserved award.
Thank you.
And, you have made your mark on the universe. The work you do is important. We need more like you. And you're my friend and colleague in a weird kind of way. We're similarly, oddly, weirdly like-minded.
We are.
But so appreciate you taking the time. I know you're busy and you squeeze this in like en route to the airport. But we're going to keep you for one more episode. Thanks for tuning in for another episode of AdvoKAYte, Holding Healthcare Accountable. I hope you enjoyed my discussion with Ann Roberts as much as I did. I always learn from Ann, and it gives me hope to know that there are C-level suite type people like her working within healthcare who have their minds and their hearts in the right place. She's not the only one, of course, but she leads a great example of what a just and safe culture that's focused on patient safety should look like. So Ann's going to come back and join us for another episode where we're going to talk about what hospitals can do to prevent medical errors. If you didn't listen to the episode with Dr. Matt Austin, I encourage you to go back and listen to that one. Dr. Matt Austin is a Johns Hopkins PhD type doctor who studies how human factors contribute to medical errors and how human factors can be engineered away and out of medical errors so that there are fewer of them. So I want to pair that with a conversation with Ann Roberts about how the hospitals can implement these types of systems so as to reduce medical errors. So I really hope you'll go back and listen to Dr. Matt Austin and join me again for the upcoming episode with Ann Roberts. Thank you for listening.